colleagues from, okay. Dr. Kevin O'Rourke is one of my colleagues from Truman Medical Center, and he is an associate professor of emergency medicine at Truman Medical Center, Kansas City, Missouri. He's originally from Kansas City and attended the, he's originally from Kansas City and attended the Kansas University School of Medicine. He completed his emergency medicine residency training at the Ohio State University Medical Center and a point of care ultrasound fellowship at New York Methodist Hospital. He moved back to Kansas City 6 years ago and serves as the Director of Clinical Operations for Truman Medical Center, University Health. His interests include teaching, quality improvement, and operational efficiency. And from a personal standpoint, I'd like to thank Dr. O'Rourke for embracing the invitation to do this program, as well as some of the initiatives that he's taken to improve the care of our sickle cell patients in our ED. So Dr. O'Rourke, the floor is yours.
Thank you, Donna, for that warm welcome. I'm trying to share my screen. Is it working a little bit?
Yes.
I'm seeing it.
We see your screen, and then hopefully you have video capability as well. If you want to share your video, you can.
Like show my face?
Yeah, it's up to you.
No, actually, I'm happy to show my face.
Okay, thank you.
Hold on. Okay.
Yay.
All right, just bringing my slides back up. Can you, do you see, is this a good view of my slides or no?
Looks good to me.
Looks good to you? All right. All right. All right, so as Ms. Donna said, I'm Kevin O'Rourke. I am an emergency physician, and I serve as the Director of Clinical Operations for Truman Medical Center's emergency department. And so I hope I have interesting things to say after the last presenter. I feel like I'm going to be, I feel like I have big shoes to fill after that one. I wish I would have gone first. You know, I would say my expertise isn't really in sickle cell disease specifically, but more in emergency department operations, and kind of, I'm very interested in developing multidisciplinary care plans so patients get the best care and consistent care every time they present to the emergency department. So I'm going to spend the next half hour or so talking to you about what we do at Truman and kind of how we have developed plans and what we do for patients with sickle cell disease specifically, but kind of any patients with chronic diseases. This is kind of how we approach their care. Okay, so as the last speaker talked about, you know, caring for patients with sickle cell disease should be a multidisciplinary effort. All providers who touch the patient in any way should, sorry, my camera here. All right, so all providers who have a relationship with the patient should be involved. So this is their primary care physician. This is nurses. These are hematologists. Advanced practice providers. Sorry, I'm like struggling with my camera here. I'm just gonna turn it off. Inpatient doctors and nurses, ED nurses and doctors. So personally, I see the ED as kind of the bridge between the outpatient world and the inpatient world. And we should all be talking to each other and figuring out how to best care for the patient. In the emergency department, we should strive to make the patient experience a positive one. There's no reason that people should come to the emergency department and be treated poorly. And so, every day I try to elevate the patient's experience. I once had a wise attending tell me when I was a resident that people come to the emergency department for three main reasons. One, because they're in pain, two, because they're scared, and three, because they're bleeding. So those are kind of the three main reasons. And so obviously sickle cell patients, patients with sickle cell disease are in pain, and a lot of times they're scared about what's going on. So negative ED experiences make patients guarded and mistrustful, and showing empathy and patience is important in caring for patients with sickle cell disease. And it's important for any patient who presents to us in pain. So I'm going to kind of reiterate a lot of the things that Dr. Kavanaugh said, unfortunately or fortunately, but it'll help you learn it. So in 2014, the NHLBI, National Heart, Lung, Blood Institute, came out with some guidelines, and there were some things in there that talked about the emergency department and kind of how the recommendations. So the first one I want to talk about is triage. So the goal from the NHLBI standpoint is you want to decrease the amount of time in the waiting room. And their recommendation is to triage all patients with sickle cell disease as an ESI level 2, so emergency severity index level 2. So again, this is your second highest level of acuity, your first highest being patients with trauma or stroke or heart attacks. And then kind of right below that would be your level 2 patients. And so the recommendation is patients should be triaged at level 2. This is not only based upon the potential morbidity and mortality associated with sickle cell disease, but also the anticipated resources that you're going to be required to care for the patient and their pain level. And the emergency department, we're definitely biased, I would say, as far as patients who present to us a lot, who we see frequently, and that bias can lead to negative experiences, not only for the patient, but also for the providers. And so we need to remember in the emergency department that the typical person with sickle cell disease only experiences one vaso-occlusive crisis per year. And 40% of patients have no crises in a year. And so we're biased by the 1% who experience more than 6 crises per year. And so we need to kind of reframe our perspective and realize that, what we see as typical isn't really typical. There's also been some research that shows that patients with greater than 3 admissions for vaso-occlusive crisis in a year are at an increased risk of death. And so, these patients who we see a lot, we need to realize that, the potential for morbidity and mortality is higher than what we think it is. So again, so we screen them as about, I don't know, I guess I don't think it's been 7 years, but probably 5 years ago, we started triaging all of our sickle cell patients who present with a vaso-occlusive crisis, pain, or any other complications from their sickle cells level 2. And this does a few things. One, it prompts us to get them to a room quicker, to get seen by provider faster. It serves as a visual cue because they're a different color on the board. They're a yellow instead of a green. And so that also cues our eye to be like, okay, this patient has potential to be sicker. And so let's get in there faster, see them faster, get things going for them faster. So the next part of your triage, you're going to screen for the complications of sickle cell disease. So asking about fever, chest pain, shortness of breath, abdominal pain, stroke symptoms. And so those kind of check off the big boxes of the complications that you're worried about. And then the third goal is to deliver the first dose of pain medication within 30 minutes of arrival or within 60 minutes of arrival. Some places say we try to do within 30 minutes of arrival. And so that may be in triage. And so you may need to develop, if you can't get patients back into rooms quick enough because your emergency department is so backed up, you may need to deliver that first dose of medication in triage. And so coming up with a system where a physician or an advanced practice provider can see the patient quickly in triage, order a dose of pain medication for them so that you can start treating them faster. It's going to lead to patient satisfaction. It will lead to decreased rates of admission, and it'll really leads to overall satisfaction. And in the era of COVID, and everyone's seen the headlines about the surges of patients in the emergency department over the last month, you may need to consider alternative treatment spaces. So at Truman, we readily use hallway beds. We put patients in the hallways. And so that may be an option for you. Where I used to work in New York, we actually had an asthma bay section, which was 6 lazy boy chairs. I have no idea what they do with it now in the era of COVID, because I can't imagine these people all breathing around each other. But finding an alternative place where people can get treated, especially right now with our long wait times in emergency departments across America. So once the patient gets to a room and you're able to see them, you want to provide appropriate emergency department care. So you want to obtain an appropriate H&P. And as Dr. Kavanaugh commented, you want to ask relevant, pertinent questions and kind of keep it to the questions that you need to know right then, get their pain treated, and then you can go back and ask more questions and make sure you're covering everything and ruling out any life-threatening complications of their sickle cell disease. And then you perform an appropriate workup. So patients with sickle cell disease obviously have a high morbidity and mortality. The median lifespan for somebody with hemoglobin SS disease is in the 40s, and for hemoglobin SC disease, it's in the 60s. So when patients present to the ED, we should evaluate them for any acute complications of their sickle cell disease. We should evaluate their pain and ask them, is this typical for your vaso-occlusive crisis pain? And if not, if the pain's atypical or different, then we need to undergo some sort of further investigation to rule out other causes of their pain while also treating their pain. We shouldn't be waiting to treat their pain until we figured out exactly what the cause of it is. But, things to remember that up to 40% of patients with sickle cell disease experience acute chest syndrome in their life. Another 45% have a stroke before the age of 45. Another 30% have chronic kidney disease. 30-40% have avascular necrosis of their large joints, especially like their hips and their shoulders, making mobility difficult. Another 30% experience pulmonary hypertension. So these people have a huge comorbidities, and the potential is great for something to be seriously wrong. And so that should always be in the front of your mind when you're evaluating someone with sickle cell disease. So again, I feel like I'm just echoing Dr. Kavanaugh, but consistency is key. So you don't want the patient with sickle cell disease to have different experiences every single time they present to the emergency department. And so the National Heart, Lung, Blood Institute suggests you call their hematologist to figure out their analgesic regimen. And I would argue if you're calling hematologists during the emergency department visit, you've already failed. This should be figured out before the patient gets to the emergency department. This should be in their chart for everyone to see every single time they present to every time they access care at your healthcare center. So you should trust the patient's report of pain until you have a reason not to. The patient's report of pain is the gold standard in treating patients with sickle cell disease. Pain is a subjective experience, and there's no vital sign or lab test that's going to tell you if a patient with sickle cell disease is in pain. Likewise, these patients are taught to use distraction mechanisms and biofeedback to control their pain. So, you'll see nurses chart like the patient's eating, the patient's sleeping, doesn't appear in pain. So just because they're eating, sleeping, Snapchatting, that doesn't mean they aren't in pain. So you should treat their pain unless, you have a reason not to. And again, go back to the goal is to administer pain medication within 30 minutes of arrival. At Truman, we have an ED sickle cell order set that is built that has different pain medications in it. It has different doses of pain medications in it. And it also has the 2 additional PRN doses every 30 minutes. So the physician can order 1 dose, and then it has these 2 subsequent doses 30 minutes apart. And this lets the nurse and the patient drive the redosing of the pain medication without needing to find the physician for another order, because the doctor gets busy, there's a trauma, there's a stroke, they've moved on to another room, the nurse can't get a hold of them, and then you're talking to delays without the patient's pain being treated. And so building an order set where the nurse and the patient can kind of drive the care is important to helping the patient's pain get under control faster.
Dr. O'Rourke, this is Shauna. I'm just breaking in to say thank you and just to let you know you have 10 minutes left.
Sure, thanks.
Thank you.
So another thing that we changed in our emergency department a few years ago was subcutaneous versus IM delivery of pain medication. So the NHBLI recommends pain control via that intravenous route. However, I live in the real world where it's just not always possible. And I think our patients with sickle cell disease also know that it's not always possible. So we try to provide IV pain medication when we can, but for those patients who it's IV access is difficult, we converted all of our protocols to the subcutaneous route about 6 years ago. And so I think that has made patients happier because they're not getting IM pokes. The subcutaneous route is much more tolerable, I would say. But as far as subQ versus IM, subQ has better absorption of the pain medication. The pain medication, it mimics IV pharmacokinetics. It decreases your risk of sterile abscesses and it increases patient satisfaction. So you should, if you're using a lot of IM pain medication, you should really reconsider things. And even talking, Dr. Kavanaugh talked about intranasal routes of pain medication. So subQ is also another good option for patients who have difficulty starting IVs. And I think patients are okay with that as long as you have that conversation with them. So the last thing I wanted to talk about was individual care plans. And so at Truman, we have had over 100, probably over 150 patients on individual care plans. And that's not all, those aren't all patients with sickle cell disease, but patients with multiple chronic medical conditions. But again, as I said, that the NHBLI, they say you should try to contact the patient's sickle cell physician for analgesic suggestions. And but again, if you're doing that during the ED visit, you've already failed in your care of this patient. This should be done before the patient presents to the emergency department. So the way we develop individual care plans is that we work with a multidisciplinary team to develop that care plan, and then we share that plan and develop that plan with the patient. So this encourages consistency across the acute care areas. So whether or not the patient's in the emergency department, in the inpatient unit, or in our sickle cell urgent care area, the patient's getting the same medications, the same care every single place they go. So this allows the patient to know what to expect when they need to access the healthcare system. So our multidisciplinary care team consists of ED physicians, which is usually me, inpatient physicians, our sickle cell providers, our social work, pharmacists, our nurse case management team, and nursing leadership from both the ED and the inpatient units. So we take a multidisciplinary view of the patient. We look at pain control, we look at their medication compliance, we look at appointment compliance. And then the other thing we take into big consideration is, if patients are presenting a lot, kind of what's going on, why are they presenting to the emergency department a lot? Why are they accessing the system a lot? What are their barriers to their care? So are they homeless, or do they have unstable housing? Do they have transportation issues? Do they have children at home that they have to care for during the day, but someone else comes home at night and can watch the children, and then they come to the emergency department? And so we kind of try to take a holistic view of everything that could be going on with the patient, and so that we can better help meet their needs. About 30% of patients with sickle cell disease have underlying depression or anxiety, not surprisingly. And so, we also look at, are there behavioral health needs that they need? Do they need to see any of our addiction specialists? So again, we kind of try to look at it in a holistic way. And then we put these plans in a place where everyone can access them. So Dr. Kavanaugh showed you a screenshot of Epic. We use Cerner. And so when the patient presents to the emergency department, there's this little icon that pops up on their chart, and you can click on that and it opens up the multidisciplinary care plan. And so, so that's our flag on the chart, so that providers know that the patient has a care plan when they present, and then everyone can see it. And again, this way the patient gets the same care every single time they present to the emergency department. And so that makes the patients happier, that makes the nurses happier, that makes the doctors happier. And I think it just makes for a better experience for everyone. And then The other thing that I would recommend is putting the care plan in a place where the patient can access it through their portal. When in the era of, like, patient access and stuff, it's nice for the patient to be able to pull up their plan on their phone, so that if they are somewhere else in town and they're closer to another hospital and they go there, they can pull up their plan. Or if they're out of town and they have a vaso-occlusive crisis, they can go to the hospital and they can pull up their plan and show them, look, this is what happens at my home hospital. And this way the other providers can trust what they're telling them, and they can look at that plan themselves, and they can say, okay, we can do this for you. And so it kind of just gives everyone power and the ability to kind of take control of their care. So in conclusion, sickle cell disease obviously has a high morbidity and mortality, and we should always be taking that into consideration when we're evaluating patients who present to the emergency department. Patients should be evaluated quickly, they should be treated appropriately, and complications from their disease should be ruled out. And developing a care plan before the patient needs one is my biggest take-home message today. So it leads to consistency and satisfaction for both patients and providers, and leads to just a better overall experience in the emergency department. Any questions? Let's see.
Am I unmute? All right. Dr. O'Rourke,
Yes.
thank you so much. And you did, you stepped right into Dr. Kavanaugh's big shoes. And one of the reasons I asked you to present is that I'm so proud that our department, and I didn't even know how well we were meeting some of the guidelines until you kind of talked through it today. So can't say how proud I am of you and of our emergency department. Are there any questions that anybody would like to ask Dr. O'Rourke? Let's see, there's a chat here. No. Okay, if you think of some later on, just send them our way and we'll get them answered. Thanks again, Dr. O'Rourke.
Thanks, Sana. Thanks, Kevin, for the
See you at work.
invitation.
Thank you. So
All right.
I will stop the recording.